Imagine this. You go to the doctor for a routine checkup, feeling perfectly fine. A screening test comes back positive, and suddenly you're told that you might have a life-threatening disease. Panic sets in. But months later, after countless tests, treatments, and sleepless nights, you find out it was a false alarm. Scary, right? But here's the kicker. This happens far more often than you think. You might be wondering, what does this have to do with healthcare and disease prevention? Well, today we are diving into the complex world of disease screening, how it works, its benefits, and the hidden risks that most people never think about. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal, and I'm a primary care physician in Connecticut, and I run my own medical practice. An ounce of prevention is worth a pound of cure. However, an ounce of overdiagnosis is also worth a pound of profits. The central purpose of screening is to identify disease early and start treatment early to reduce the probability of symptoms, morbidity, and mortality. As far as I know, WHO published the first ever handbook which laid out the principles of disease screening, which you can see on the slide. These principles are meant to guide decisions about whether or not to screen, and they emphasize the need to balance the potential benefits and harms of screening. I've highlighted 3 principles that are especially fraught with nuances and bias and can easily tilt the balance from benefit to harm. Before we dive into the nuances, however, let's take a look at what makes a good screening test. The first criteria is validity. Validity refers to the test's ability to accurately distinguish between individuals who have a disease and those who do not. It is typically assessed using sensitivity and specificity. Next is reliability. Reliability refers to a test's ability to consistently produce the same results when repeated generally under the same conditions. It is sometimes called reproducibility or precision. For example, checking blood pressure at different times may lead to different values. Blood pressure results may differ depending on the patient's expertise in taking their own blood pressure. Or the blood pressure may be different in the doctor's office versus at home. Next is yield. The yield is the number of new people found to have the disease as a result of the disease screening program. Yield is directly proportional to disease prevalence in the population and access to medical care. The highest yields will be obtained from screening for a highly prevalent condition in a population that has minimal access to medical care. On the other hand, when people have access to medical care, fewer new diseases are likely to be discovered through screening, as the disease will be found as part of routine medical care. This is called the yield paradox. Furthermore, most screening programs cast a wide net, tolerating more false positives to avoid missing a diagnosis. As a result, when a screening program is implemented in a region with good access to medical care, a higher percentage of new diseases identified through screening are more likely to be false positives. For example, the depression screening and follow-up plan quality measure will find more people with depression when people lack access to medical care. Mandating PCPs to conduct a mass screening campaign for their patients during an office visit that already have access to medical care is much more likely to yield false positives. And the last is cost effectiveness. The screening test should be affordable and provide good value when applied to large populations. This also raises the question of who accrues this value. The entire population, a select number of people such as those who are high risk, medical providers, or manufacturers of screening tests. Besides the criteria I mentioned before, there are other criteria to decide if a test should be used as a screening test, such as acceptance by people, the simplicity of performing the test, and the availability of follow-up services. Now let's talk about the role of disease definition in screening for disease. Before we can recognize a latent or early symptomatic stage, we need to define the disease. I discussed the role of natural history of disease, or my preferred term biologic pathway, in defining a disease in my last video, What is a Disease? The big questions that we need to think about before screening are: where in the biologic pathway do we screen? In other words, how do we define the latent stage? How long will it take for the disease to progress from latent stage? That is, when screening is performed, to clinical symptoms. Do we have a treatment that works in the latent stage? And what are the side effects and how will they affect quality of life after treatment? Physiologic variables such as blood pressure, blood sugar, and even cancer cells are continuously distributed around the mean, conforming to a normal or skewed normal curve. This distribution can be either bimodal or unimodal. If a distribution of physiologic variables is bimodal, there will be an overlap between individuals considered to be normal and those with the disease. Take cancer as an example. During normal cell turnover, many abnormal cells are produced in the human body, which could be classified as cancer cells under a microscope. In healthy individuals, the immune system eliminates these abnormal cells before they can cause disease. However, when these cells evade the immune system, they can lead to symptoms, which we recognize as cancer today. This creates a significant overlap between individuals who are normal, that is, have cancer cells but no symptoms, and those who have symptomatic cancer, which is represented by the shaded area in the graph on the slide. One could argue that the latent stage in this case consists of individuals without symptoms who fall under the shaded area of the normal curve, excluding those with the disease. These individuals have cancer cells that may eventually cause symptoms. Current screening strategies aim to identify all such individuals operating under the assumption that all cancer cells are harmful. This approach overlooks the fact that for the vast majority of people, these cancer cells will never progress to cause symptoms. Unimodal distribution. In a unimodal distribution, there is no clear distinction between normal and diseased. Instead, clinical studies are used to establish an artificial cutoff point which classifies everyone above the threshold as diseased. For example, fasting blood sugar greater than 126 is diabetes, blood pressure greater than 140 over 190 is hypertension. You can also make the case that cancer cells are distributed similarly, especially if you think about it from a physiology lens of normal cell repair, which leads to production of dysplastic cells and which are cleared by the body's immune system. The challenge with determining a cutoff point in a unimodal curve is that the law of diminishing return applies if we keep lowering the cutoff values. Lowering the cutoff value may classify more healthy individuals as diseased, leading to unnecessary treatment and lower quality of life. Once these normal individuals are diagnosed with a disease, it may also affect their disability and life insurance premiums. Lies, damned lies, and statistics. That headline is a little bit over the top, but there's some truth to it. There are statistical techniques that can give the appearance of efficacy to a test when in fact the test is completely useless. Also, I will use cancer screening as an example to lay the groundwork for my future videos. In the case of a bimodal distribution of disease, we use sensitivity specificity to decide on a screening test. Since there's no perfect test, we have to make trade-offs. If we decide on a screening test that has higher sensitivity, we will find more false positives. For example, the original studies of breast cancer screening were based on film-based mammograms. The mammograms in use today are much more sensitive with a lot more false positives. In a population without a screening program, let's assume that the prevalence of progressive cancer is approximately 1,000 people. We follow these people for 5 years, and 5 years later, 400 are living and 600 died. In this case, the 5-year survival rate is calculated to be 40%. Now let's implement a screening program. In addition to the 1,000 people with progressive cancer, let's say we find an additional 2,000 people with non-progressive cancer using the screening tests. These non-progressive cancers will never cause a problem in the person's lifetime. 5 years later, out of these original 1,000 people, we still have 400 alive and 600 dead. However, since the cancer did not progress, all the 2,000 people are still alive. In this case now, the 5-year survival rate is 80%. We just improved the survival rates of cancer in a population by implementing a screening test statistically without any change in patient outcomes. Next is lead time bias. Let's assume that cancer in a person starts at age 50 and progresses to cause symptoms at age 67, and the person dies at age 70. In this case, the 5-year survival rate is 0%. Now, if we implement a screening program, we may catch the same cancer at age 60. However, the person still dies at age 70. In this case, statistically, the 5-year survival rate is now 100%. All we did was using the screening test is to find the cancer earlier in life, but it did not prolong the person's lifespan. And the last is length time bias. For rapidly progressive cancers, the screening interval may be too short. In this example, a screening program only finds one progressive cancer via screening, and 5 would have become symptomatic even before the person had a chance to undergo screening. For slowly progressive cancers, however, the screening test finds a lot more. In example, 7 out of 10 and 1 slowly progressive cancer, irrespective of screening. This is the central dilemma of screening. For rapidly progressive cancers, the screening interval is too long, and for slowly progressive cancers, it is too short. If we decrease the screening interval, we may find more rapidly progressive cancers, but risk side effects of screening and also finding many more false positives in other people. As medical treatment for a disease improves, the benefits of screening diminish, and the risk of harm from treating false positives increases. We have much better treatments for breast and prostate cancer than 30 to 40 years ago when the original studies for screening were done. These modern treatments have dramatically improved survival rates, with unintended side effect of possibly reducing the benefit from screening. When healthcare systems implement screening based on limited or preliminary data, that early detection improves outcomes, it can become culturally ingrained, almost like folklore. This cultural acceptance can make it ethically challenging to conduct studies comparing treatments with placebo once an early diagnosis is made through screening. Imagine attempting to conduct a study today comparing mammograms to placebo. Digital mammograms used today are much more sensitive than older film-based mammograms. The higher sensitivity will detect more abnormalities with a higher likelihood of false positives, leading to harm in the screened population. However, because mammography is already widely accepted as a standard screening tool, conducting such a study to evaluate its true benefits versus harm would likely be considered unethical. This is due to the cultural and medical assumption that mammograms save lives, even though newer technologies may shift the balance from benefit to harm. Screening programs, while intended to improve public health, are often influenced by financial incentives. For example, more sensitive mammograms lead to more false positives and unnecessary treatment, generating higher revenue for health institutions. Or using a sensitive screening questionnaire like PHQ-9 will ensure that more people will be prescribed antidepressants. All healthcare entities, including doctors, profit from widespread screening, even when the evidence supporting the benefits is limited. However, the role of individual doctors is much more complicated. There is growing evidence of financial conflicts of interest among physicians who write the guidelines. Most doctors rely on these guidelines and don't look at the underlying evidence themselves. Therefore, guidelines have a major impact on clinical decisions made by doctors. Then doctors are humans too and have the same fear of dying, and we have seen loved ones succumb to diseases, including cancer. This means we fall prey to the same beliefs that guideline writers publish and undergo the same screening tests that have limited benefits and we tell our patients to undergo. Most doctors are employed and do what they are told by large consolidated healthcare institutions they work for. That is, generate profits. And by the way, most guideline authors also work for these large consolidated healthcare systems. Next, once a medical test is culturally ingrained and recommended by guidelines, it is generally considered medical malpractice if doctors don't perform the screening test. I discussed this phenomenon in my prior video, the quality of quality measurement. Many screening tests are also quality measures, example breast and colon cancer screening, which are directly linked to financial, reputational, and medical legal penalties for individual doctors, creating incentives to perform screening tests without discussing the nuances with patients. The unfortunate reality is that most people equate cancer with a death sentence, even though treatment has improved dramatically. Aggressive advertising by health organizations and medical test manufacturers fuels this anxiety further, creating demand for their products. While screening has repeatedly been touted as saving lives by detecting disease early, it also carries significant risks, including overdiagnoses and false positives, which can harm patients. A consolidated medical industrial complex exploits these screening tests by advertising and influencing medical guidelines, and recommending more sensitive tests with higher false positives, leading to higher profits. Remember the old proverb, "A stitch in time saves 9"? Well, sometimes in medicine, early stitches may tear the fabric of health while filling the coffers of medical industrial complex. You can find a written version with references to the material and audio podcast version on pcplens.com. If you like this video, please sign up on pcplens.com so that you don't miss the next episode when it's published. Thank you for watching this video. Goodbye.